Audio recording for this meeting has begun.
Hello everyone, this is John Marks from Lankenau Hospital. I'd like to welcome you today to the SAGES webinar, which I'm thankful to the SAGES Resident Education Committee for putting together today's presentation, and thank you to the faculty for being involved. Lena Caton has spearheaded this, and this is some of the most watched programming on SAGES. It'll ultimately go to SAGES TV, so this can be viewed on the web. We have what I think, and I hope you'll find, is a very exciting presentation today. This is geared towards the residents. There is a layout so that you can type in your questions and make comments. We'll have some questions asked and answered during the presentations, then we'll have 20 minutes at the end of the presentations for the faculty to field questions and speak with you. So please feel free to type in questions. I'll be fielding them as we go. First, we've had a little bit of a change in the order of things. I'm going to start off talking about transanal endoscopic microsurgery and some of the changes in minimally invasive surgery and colorectal surgery. Tonia Young-Fadok from the Mayo Clinic, we're happy to have and fortunate to have. She's going to be talking about developments in inflammatory bowel disease and the role of laparoscopy in the treatment of Crohn's patients and those patients with ulcerative colitis. Following this, Elsa Valsdottir from University of Iceland will be speaking to us, and she's a assistant professor there, and we're excited to hear her speak about something that I think will be near and dear to the hearts of the residents, which is getting started, beginning in practice, and some of the pitfalls and pearls that occur, and the challenges and opportunities that exist for people bringing in new procedures to a community. She was the first to bring laparoscopic surgery to her country for colorectal surgery. Tony Senagore will be talking about technical advances and tricks in colorectal surgery. Tony's the head of colorectal surgery at the University of Southern California and the former president of the American Society of Colorectal Surgery. And then Dan Geisler from Allegheny General Hospital will be speaking on single-port colorectal surgery, when and how to do it. He has probably the largest personal experience in the world of single-port colon surgery. So I think it should be an exciting evening. Please feel free to make use of the typing in the questions as you have them. And so with that, I'm going to get started with my presentation. Okay, so I'm contractually obligated to start with a slide of my father's watercolor. This is a painting of Philadelphia, and this is especially germane for SAGES, as he was the founding president of SAGES. So I come to this field quite naturally. So I'm going to be speaking to you now about minimally invasive colorectal surgery, both today and in the future. Little technical issues here. All right. So this is Lankenau Hospital, just in the outskirts of Philadelphia on the former Overbrook Golf Course. This is where we work. We have a fellowship in minimally invasive colorectal surgery for any of you interested out there. These are my speaker disclosures, so basically I'm willing to speak with whoever is interested in hearing what I have to say. And so to get started, the first nodes procedure was reported in 2003. This was a successful transgastric appendectomy tubal ligation performed by Drs. Reddy and Rao in India. And that really set off a tremendous round of excitement in the surgical community. In the United States, Mark Geisler at Columbia was the first one to perform a nodes procedure in 2007. This was a transvaginal cholecystectomy, and really was a hybrid laparoscopic procedure done transvaginally with some laparoscopic assistance through ports, and really has brought things to the U.S. And it raised a question in many of our minds, what's a natural evolution of things? So we've gone from open surgery to laparoscopic surgery, and now from laparoscopic surgery, we're going to hear today some more about single port surgery. In doing that, it's a change in access, but the procedure is pretty much the same, although multiply modified. When we talk about node surgery, it's really somewhat of a different evolution. And so what I'm planning on talking to you today about is about that evolution and what role endoluminal surgery, or TEM surgery, has to play. So the difference is not only a difference in access, but using flexible instruments, and the visualization is quite different. So if you think about access, if you were to extrapolate, this is some data from umbilical hernia rates in laparoscopic cholecystectomy. It gave an incidence of 0.8% of patients in a group of 1,300 patients. If you had that same failure rate of closure in doing something in a nodes fashion, disrupting a healthy organ to get to a diseased one, what you would end up with is 10 to 13 perforated stomachs or colostomies in these patients, and all the patients that you were considering doing in this fashion would have to have a bowel prep for a simple cholecystectomy or appendectomy, which is really somewhat not feasible. So what about transanal endoscopic microsurgery? This, I would submit to you, is really the ultimate in minimally invasive surgery. It's really the only established experience in endoluminal surgery. And what about it for a platform for nodes? Well, the logic of nodes in colorectal surgery is quite strong, because you're making a defect in the target organ, which is really the end organ, as opposed to making a defect in a healthy organ, which is just an innocent bystander to get to the disease organ. So entry into the peritoneal cavity, as we saw here during TEM resection, has already been described with safe closure and is not really problematic in and of itself. The advantages of TEM for nodes is that the working platform is stable. We have a regulated CO2 insufflation with a strong visual spatial orientation. This is quite different from the flexible orientation and challenges that occur in that fashion. It gives us the ability to remove large specimens with large instrument shafts to dissect with. The challenges to using this as an alternative to MIS procedures is that even though there's a big number, 250,000 colectomies in a year, what we're doing it for generally is benign lesions with a lot of inflammatory process, which makes it difficult, or malignancy. Generally not a good target disease to get started with any new procedure. So what we're showing here is a radical TEM resection. So this is the view. Here's an electrocautery. And what we do is we tattoo around the lesion. We use the electrocautery, and you can see how beautifully here the vessel is seen. You have very exact control when you're working. You're working with a rigid instrument. The challenge is that the lesion itself has to be in the bottom 180 degrees of what you're working on. You can see the muscularis propria here, going through the mucosa, submucosa, into muscularis propria, and then you can see the yellow of the perirectal fat. Once this is liberated, it's brought out, and you can see, as demonstrated here, this is quite a large defect involving about 2/3 of the circumference. You can see we have a small entrance into the peritoneal cavity. This is just the completion of the dissection. This shows the specimen being oriented. This is an in-block resection. You can see this is a sizable chunk of the rectum that's removed. Then this is a real true advantage of working with rigid shaft instruments. You can see it's quite simple to sew, much in the same way we sew in open or laparoscopic surgery. There's no left to right movement, so it's just an in and out. You can see here we're using these silver beads to close the defect to minimize the need to do intraluminal tying. Once that's bisected, we're taking full thickness bites. While there is an excellent optic, you can see that it is difficult. You can only work in the bottom 180 degrees of the field because, as I'll show you later, when you look at the optic, the top 180 degrees of the optic are covered, the top 180 degrees of the lumen is covered by the optic itself. So this is just showing us closing the left side of the defect. And this is the end result. Clearly an enormous benefit for this patient who otherwise would have required a low anterior resection. So this is just a little bit of our data and how we've used TEM over the years. Done 260 patients when we last looked at this. Not surprisingly, a large number of these were done for cancer, 40%. And we've been big advocates of local excision after neoadjuvant therapy, and 77 patients have been treated in that fashion. Not surprisingly, the other big number of patients were those with polyps, been used for carcinoids and other issues as well. We took our data and we compared how we did with the local excision using TEM and compared it to TME resection for T2 cancers following neoadjuvant therapy. And so what you see here from an oncologic outcome, looking at the roughly equally matched patients over the same time interval, was no difference with the local recurrence and a very respectable 3.3% local recurrence in the TEM group, 2.3% in the TME group, 95% or better 5-year survival, and normal function in both patient populations. So really what this is saying is for stage 1 cancer of the rectum after neoadjuvant therapy, the results are excellent from an oncologic standpoint, and we've been able to demonstrate that with a sustained follow-up. So where do we go kind of from here? Because what I thought I would share with you is some of the things that we're doing, pushing the envelope, and they say that necessity is the mother of invention, and what we're showing here is a patient who had a fixed tumor against the pelvic sidewall with metastatic disease. We're having a difficult time getting around it laparoscopically, and so what we did was incise at the anal canal circumferentially and then put the TEM scope, and what I'm showing here is I'm working outside of the lumen around the levators, and to the left you see the TEM view, and to the right what we have is the laparoscopic view. And so this is a picture-in-picture aspect of this. For us to complete the dissection, we're coming from below where we have a better plane. Then once we develop that plane from below, we're able to connect it from above and deliver the specimen out altogether. We look down to the pelvis, that's what the TEM looks like, and you can see the restrictions in terms of grasp. Then what we did with this, in this individual, is deliver the specimen down out through the anal canal to avoid really any significant abdominal surgery. And so this really raises the question as we move forward, are we going to ultimately be able to do more operations in this fashion, from below, avoiding an operation? So we've expanded this. We have, as you can see, a large experience with rectal cancer done laparoscopically, and this is now well over 50, a group of patients where we've been delivering the specimen transanally and then doing sphincter reconstruction. sewing the neorectum to the anal canal, avoiding any abdominal incision for specimen extraction. And clearly the benefit to the patient is that of all minimally invasive surgery is less problems. So, spoken some of laparoscopic surgery, going to endoluminal surgery, and now what about the question of single port? We have a whole session on this, so I'm not going to get into it very heavily. This is just saying that I have a big experience with laparoscopy, and that's what led us to be able to take this into single port surgery. And I think I'm going to leave this really for Dan Geisler to look at, but just make the point that for very experienced laparoscopists, there is the ability to do large resections with minimal problems. And this is just showing a single port video. I'm going to skip on that altogether. But clearly we can do better. I mean, this is, and when I say we, I mean the general surgical community. Here is a patient who's had a left colectomy. This is the picture 2 weeks post-op. This is a patient, this is actually the same patient, to my surprise, a year later. And as you can see, he had the appendectomy scar. He developed appendicitis 10 months after he was operated on. His local surgeon was afraid to do something laparoscopically because they weren't familiar with what we had done through the belly button. And so it does seem kind of crazy that the left colectomy scar is there as demonstrated compared to the appendectomy scar. And so this is why I think it's so important to have people tuned into these type of things so we can educate each other and improve the treatment of surgery that we give our patients. There are other things that are going to be coming down the line. This, for instance, is the a prototype scope from Olympus. It's a dual-channel adjustable scope, and this is a flexible scope that I think we're going to have the ability over time to do things and manipulate tissue in a way that heretofore we've been entirely unable to do. And frankly, as you think about things, we're really, for the most part, using many instruments through flexible endoscopy that our forefathers used for the previous decades in front of us. So, you know, as our experience as a group grows and we have greater experience working endoluminally and entering into the abdominal cavity, I think with experience and better technology, as we've shown here, we're going to have the ability to do things such as this, and this patient creating a ileostomy transanally after an especially large full-thickness proctectomy, entering into the abdominal cavity endoluminally, and having the ability to close things. It's really going to be by having the ability to reach up higher and having the experience to apply things that will have the ability to do things such as this, which is a nodes proctectomy. And what I'm demonstrating here is us starting the operation transanally. This is a patient who had ulcerative colitis. We thought they were too sick, and so we've done a total abdominal colectomy and endoileostomy. We thought we'd be coming back to do a pouch, but instead we found the patient pathologically at Crohn's, so we're doing a proctectomy transanally, really with a nodes approach. I put a laparoscope in just to monitor things, and we started off incising at the anus circumferentially, oversewing the rectum, and here we are operating transanally. You can see the levators, see the finger in the vagina there. That was a little too stiff, so we transitioned to put a Sills port in, and you can see the picture-in-picture in the left lower quadrant of what we're looking at. And then above how we were working, you can see the vagina there anteriorly, using an extra long shaft in order, an energy source in order to create this dissection into the abdominal cavity. Here we are going into the pouch of Douglas. You can see in the upper left side the picture of the pouch of Douglas laparoscopically, and I feel that for safety reasons, it's important to have some monitoring from above as you're progressing with this type of experience. Here we are completing the dissection circumferentially. In this fashion, we've completed the dissection. You can see the 5mm scope from above, and this is just brought around circumferentially. You can see the view abdominally as we are now liberating this specimen entirely and delivering it from below, and then this is the picture from below transanally as the rectum is delivered. And it's just a simple matter of overseeing the perineum, the perineal wound, and so that's the only incision the patient had.
And us transecting this.
Whatsoever. So in
Specimen is
conclusion,
now
I would
removed.
say to you that TEM
And what we see here
offers us
is the anterior wall amount of defect we're left with, trying to determine how it is we're going to be able to close this, and you can see the size of the defect in the rectal wall that we've created.
No abdominal incision at all. It comes to
Instruments
us to explore ways
and the lumen is washed with dilute betadine, changed. See pulsating there at the 3 o'clock area, the left.
Maximize the benefit to our patients while minimizing the risk of major abdominal surgery. And it really is going to come upon those in the community, the surgeons who are listening, the young surgeons, to talk about the challenges and the opportunities. The challenges that will exist, certainly, are those of oncologic issues, the technical challenges of how we're going to be able to utilize and address problems surgically with the equipment that we have, and it will be up to us partnering with industry to express what we need and for them to give us those opportunities so that we can do the best for our patients and then functionally see how the patients do afterwards, because ultimately that's going to be the driver. I'm going to just leave you with this quote from Winston Churchill: "It's better to take change by the hand than have it take you by the throat." Thank you very much for your attention. And I'm going to open the floor up. There is a question by James Bittner. Following radical TEM resection, have you noted a significant rate of stricture or leak? And how can you ensure that no twisting occurs after pulling the rectum through the anus? Well, we published our experience with radical TEM. The stricture rate is extraordinarily low because you have a 4-centimeter diameter scope in that you're operating through, and so it's almost impossible to narrow things. As for the leak rate, we did note a 26% incidence of partial leak, partial breakdown of the wound, but for the most part, these are handled almost entirely with oral antibiotics, with an incidence of only 2% of people needing a colostomy to handle that. And the question regarding the twisting as you're pulling something through the rectum, you need to have this monitored from someone from above to look at the mesentery and look at the bowel as it comes out to make sure it's not rotated. That's an excellent point. You wouldn't want to leave the abdominal cavity altogether and deliver things unwatched from below. Lastly, there's a question: would TEM notes change within the context of patients with the possibility of endometriosis? Oftentimes, that's a very difficult patient population to operate upon, but clearly it is an option. So I'll leave you with this. Notes in single port surgery and all of surgery, it's really a journey, not a destination. It's a matter of us using the tools we have in front of us and matching it with the problems that we're faced with. So thank you very much. And with this, we're now going to segue to Tonia Young-Fadok, who's the Chief of Colorectal Surgery at the Mayo Clinic in Scottsdale. Tonia's going to be speaking to us about new developments in inflammatory bowel disease, the role of laparoscopy in Crohn's disease, and in pouch surgery.
Hi, John. Thanks very much. Can you hear me okay? Are you able to hear me?
Yes, we can hear you fine, Tonia.
Wonderful. Well, welcome to everyone who is logged in. And John, thank you very much for asking me to speak, which is on current developments in laparoscopic surgery for IBD. I have no disclosures that are pertinent to this presentation, and I'd like to say welcome from the desert. So with laparoscopic colectomy, there are general issues in terms of dealing with a large specimen, working in multiple quadrants of the abdominal cavity, dealing with rather large blood vessels, reestablishing bowel continuity, and for the most part needing to extract the specimen intact. Issues that are specific to Crohn's disease, and I'll start with Crohn's first, are, for example, with ileocolic Crohn's disease, fistulas, abscess, phlegmon. The mesentery can often be very thickened and shortened, and due to the steroids and immunosuppressives that patients have often been on, their tissues are very friable. Crohn's colitis, the issue there is obviously the extent of the disease, and then you have the patient factors themselves, one of which I mentioned, immunosuppression, and the other malnutrition. Early on, it seemed that the opinion regarding laparoscopy for Crohn's disease was that it's far too hard. The features of the disease were such that with the inflammation, these procedures were unlikely to be successful laparoscopically, and many of these patients had had prior surgery. I think now, though, that amongst colorectal surgeons who have experience with laparoscopy, certainly a laparoscopic approach is the procedure of choice for first-time ileocolic disease. But what about more complex disease? A multi-center review looked at predictors of conversion, 135 patients over 6 centers, and this was very early on in the experience. The overall conversion rate the ileocecal disease, when it was limited, had a very low conversion rate of 4.4%. Resulted in approximately a quarter of patients being converted, and the same with fistulas. Palpable phlegmon led to conversion in over half of the patients. So I want to look at current status for ileocecal disease, diffuse small bowel disease, and colonic disease. Associated difficulties, as you see here, of obstruction, fistula, abscess, phlegm disease, and obviously prior surgery. Basic principles involve careful preoperative planning. There needs to be a full upper and lower evaluation of the GI. It's possible to sometimes evaluate fistula. I do like to use a bowel prep, particularly fluid and stool in the colon and small bowel, and makes it easy. Someone on whom CT has demonstrated a phlegmon, I would consider urethral stents, and then depending on whether I'm access for transanal stapling or even intraoperative colonoscopy. The operative approach involves decisions regarding the site of away from prior incisions if the patient is doing a rapid assessment of adhesions and the choices between lateral to medial and medial to mobilizing the in the case, for example, when operating on that the small bowel can be brought out of the pelvis. Do mobilize the entire right colon to the also, the incision overlies the root of the small bowel. Incision that the specimen is brought through. There are issues additionally related to whether acute or whether it's elective. Oftentimes in acute symptoms when they have a tense amp. Has compensated and it's still possible. Here is the CT scan of C33, treated for many years by what I assume was an old school gastroenterologist. Told her not to return until could only eat baby food. The small bowel that you see here are not the colon, but they are the small. Clip here showing picturing. Here's the small bowel exteriorized. Laparoscope itself, but you can see just 2 ports in the left lower quadrant, and can be drained preoperatively if they are apparent on CT. Abscesses are usually small and they can be controlled. Small bowel disease can sometimes be difficult to evaluate. Section is planned, then even with a laparoscopic Baker tube, which is a very long tube that has a balloon on the end that balloon blown up and then brought back to mark. Particularly important, I think, in patients who've been treated with as pictures that have very little erosal manifestation and can only be detected. It shows how the entire small bowel can be patient who has a phlegma and examining the patient preoperative. Approach fixation and start approaching the area from areas of normal. Involved in a fistula from the primary disease, also has dual involvement, or has just mobilized and then exteriorized en bloc. Suture the area of bystander disease. Very dilated small bowel. Sigmoid, which is markedly smaller. Mobilization, again the small bowel. Very gently exteriorized, but with patients it can be done. Here they've been resected with a, on the right of the picture, prior operations, that does not necessarily preclude a laparoscopic approach. The site operation was actually laparoscopic. Obviously, there are multiple operations. I will typically transect potentially pouches on patients. So it's important here to plan ahead, use cases based on experience, really. As far as having a backup plan, converting, alternating the approach if it's not safe to continue laparoscopic. Moving to laparoscopic proctoctomy. Additionally, and more commonly, early series showed longer OR time. It was longer, but actually in this series there was no paper, which was a comparative study, not a that it was felt that on specimen through a fan steel incision may was the first paper to show separate stomacite in either lower midline. All those incisions probably added up to a. So we attempted to simplify. Use fewer ports and rethink where the extraction incision. Basic building blocks of this procedure are the mobilization for right colectomy, mobilization for we changed this to using 4 ports in a diamond shape. Port site incision, not approach this in steps, mobilizing the left colon. So this was our first attempt at simplifying slight difference in length of the incision. Larson from Mayo had 100 laparoscopic assisted and 25 were hand. The laparoscopic OR time was patients were also similar. Moved time to bowel movement. Laparoscopic cases, the OR time was actually shorter. So next, well, as John has mentioned, using the ileostomy site as support and the extraction site for the years, we have gone from looked at this in our own practice. Been a trend towards decreased length of James, if you sorry, not James, Steve, if you're on the line, is this an okay time to switch to a couple of minutes of video? But not John's video.
Related stapler.
Steve is working on this. I had a single.
With the bipolar device, the sigmoid mesentery is divided. The mesentery of the left and the transverse colon is divided intracorporeally.
I'll just show the last couple of slides. Oh, no, that was it. Okay.
The specimen is exteriorized via the incision.
Showing the exteriorization. It is, I think anyone who is doing these single incision cases.
The remaining mesentery of the right colon is divided, preserving the ileocholic pedicle. The terminal ileum is transected and a 15 centimeter ileal J pouch is fashioned and returned into the abdomen. The anastomosis is constructed using a EEA. Before firing, the cut edge of the ileal mesentery is followed to avoid any torsion of the pouch mesentery. The ileum proximal to the pouch is used for the diverting loop ileostomy. The final appearance of the abdomen with the entire procedure performed via the ileostomy site.
Steve, if we can go back to the PowerPoint. So just as a comparison, this was the stomach site is moved videotape this so that we can see what we did wrong.
Tonia, thank you so much for a tremendous presentation there, as always. Maybe one question before we go. There's a question from the group. Do you notice any transient ischemia of the dilated small bowel exteriorizing through such a small benign incision?
Not yet. I found that you can control that. It's important not to let those dilated loops of bowel kind of hang off the side of the abdomen, so to keep them contained up on the abdominal wall so it's not pulling on the mesentery. And basically just being very careful about exteriorizing. That fluid can be milked out of the bowel into the loops that are already exteriorized as you're pulling additional loops through. It's amazing how much can be brought through an incision like that. And
I think I speak for everyone for applauding you on a tremendous presentation as well as a tremendous experience. Hopefully you'll be able to stick around.
I'm sticking around.
Okay. Well, we're going to move on to Elsa Valsdottir. It is with particular pride and pleasure that I introduce Elsa, who's faculty, associate professor at the University of Iceland Medical School, and who's going to speak with you about starting in practice and what it is she was faced with. Elsa?
Thank you, John. Can you hear me okay?
I can hear you perfectly. I think
okay, perfect.
Elsa's coming to us 1 o'clock her time, so she's making a tremendous effort on this part.
Okay, so we're going to take a little break from videos and hardcore data and spend the next few minutes just going over my experience of coming out in practice and starting to perform laparoscopic surgery in my community. I am currently, as Dr. Mark said, working in Iceland at the University Hospital, and the things that I would like to cover with you are what are the things that you can do while you are still in residency to prepare yourself for being independent, what things you have to look at when you're choosing your fellowship if you're planning a colorectal laparoscopic career, how to build your team once you get out there in the real world, about a little something about how to pick your first cases, encouraging referrals, and how to reach out to the patients. So if we start with what you can do right now while you're still in residency, and there is actually a lot you can do, and probably the single one most important thing is to stay awake during the case. Now, I'm sure we can all recall long laparoscopic cases, the lights are turned off, the mood is kind of quiet, and you're hanging on a camera or you're hanging on to a retractor and you're not doing much, or at least you don't feel that you're doing much. And I'm sure all of us have at one point or the other, maybe not fallen asleep, but sort of drifted away during the case. But every case is an opportunity to learn. Even if you are not performing the case, there are many points that you can pay attention to and learn from, and that you need to know when you are finally the one doing the case. So you pay attention to the little things, like how is the room set up, where is the equipment positioned, where is the surgeon standing, where are the monitors placed, how does the surgeon choose the port sites, what kind of instruments does he or she use, and why? What are the order of the steps of the procedure? As you're standing there, go over the case in your mind and try to anticipate what's coming up next. You basically should be able to dictate the case beforehand so you can be better prepared to what is coming next. And pay attention to the flow of the procedure. Especially in colorectal surgery, when you're doing it laparoscopically, you are working in multiple quadrants, and the way you move from one place to the other can reduce the time significantly if you do so in an efficient manner. And ask questions. Ask why. Why are you doing this? Why do you place your ports that way? Why do you use the Babcock rather than the Grasper? Is there an advantage to using a 5mm camera versus a 10mm camera, etc., etc.? Ask questions. Don't just stand there. And form your own opinions. As you work with different attendings, you see that people do things differently. So don't be afraid to ask questions and form your own opinion on how you prefer to do things. And keep notes. After the case, sit down for a few minutes and just jot down, did you like the way things ran through the case? Did you want to do something differently? What was good and what was bad? This is very, very helpful. It's very important, especially in the early stages of your residency, to spend time in the simulator, in the lap box. Most programs have some sort of simulation set up. It doesn't have to be a 3D virtual environment. All you need is a cardboard box and some instruments to practice the basic things. And even in your chief year, spending time in the box, suturing, tying, this is going to cut down on the time you spend in the operating room. And if your attending feels that you are adept at the more simple tasks, the more you're going to get to do during the case. So any time spent practicing is time well spent. If you go to SAGES, the annual meeting of SAGES, take the Fundamentals of Laparoscopic Skills test. It's a series of exercises that are timed, and you get a diploma describing your efficiency with fundamental laparoscopic skills. And they're not complicated and easily achievable by any senior level resident who has done any laparoscopic surgery. And I think this is helpful both for you and your self-esteem to know that you can do those things, and also helpful when you start applying for fellowships later on. And if you go to SAGES conferences or other conferences, try out different stuff in the exhibition area. I definitely feel that today even, this is like a toy shop, basically. You get all the latest equipment, all the different instruments, and don't be afraid to go out there and pick the stuff up, touch it, use it, play with it, because there's usually little time for that in the operating room. So this is the perfect environment. You're safe, no attending is watching you. You can ask all the silly questions you have about the equipment that you don't want to ask the attendings because you don't want them to think that you're stupid. So it's a safe environment, use it and play with it. So after residency comes the fellowship, and if you want to be a colorectal surgeon and you want to be a laparoscopic colorectal surgeon, you have to ask very specific questions, because all the programs claim that they do laparoscopic colorectal surgery. And probably most of them do some, but there are a large differences between the different programs in the proportion of cases being done lap. So ask them directly. Are you doing 50% of your cases, 100%? Is there a policy to always start with laparoscopy? How many members of staff are doing laparoscopic surgery? It's very suspicious if only a few of them are and everybody else is doing open surgery. That usually indicates that laparoscopic surgery isn't very high on the priority list. And once you come home from your interview, go on PubMed and look up the names of the members of faculty you visited with during the day. See if they've published something in surgical endoscopy. See if anyone is involved with work with SAGES. Those two are good indicators that there is ambitious laparoscopic opportunities at that particular program. So again, ask questions, be critical, and don't be shy about it, because this is your career we're talking about. Now, once you get out in practice, you need to realize that all surgery is a team sport, but laparoscopic surgery in particular, you need to have everybody on board. This is time consuming, it's expensive, everybody has to be on board and supportive for this to work. So when you're looking at career opportunities and you feel that you are entering a practice where laparoscopic colon surgery is not the preferred approach, you need to identify if there are any obstacles in your way. You don't want to do training in laparoscopic colorectal surgery and then end up in a practice where you don't get to use your skills. So identify your obstacles, you get the management on board, and you get your OR nurses on board. And I'm actually going to take a few minutes to go over each point. So what are the potential obstacles that you need to look at before you decide to go to work somewhere? Is your boss amiable to the idea of laparoscopic colorectal surgery? And you will find that there are surprisingly many people out there, colorectal surgeons, experienced people with great credentials, who just don't think that this is a good idea. That can be a very difficult obstacle to overcome. What about the other members of faculty? If you have your boss with you, it doesn't really matter so much if your colleagues think that laparoscopic surgery may not be the best approach, but it's something to keep in mind for sure. Now, what about the facilities? What does the OR look like? Is the room big enough for the equipment? Is the equipment in place? In most centers, the upper GI surgeons have paved the way, so they have the tilting tables, they have the towers, the booms, all the instruments, and pretty much what you have to do is just to facilitate the use of that for the colorectal team as well. If the management of the center isn't oriented towards minimally invasive surgery, then you just have to convince them. Safety really isn't longer an issue. Anyone who has read anything about laparoscopic colorectal surgery in the last 5 to 10 years realizes that this is perfectly safe in any respect. Oncologic outcomes, survival outcomes, complications with benign or malignant disease, that's not really the point of challenge. What management might be concerned with is that, yes, there is a longer operative time for laparoscopic cases, which could result in greater costs. And of course, this is something that the management of your institution is going to be very interested in. So you need to know your data. If you need to enter a discussion with management about the OR time, the cost, the safety, any of the aspects, you need to be absolutely 100% on the numbers that are out there supporting your case. The cost study, the color study, the US and the European big laparoscopic colorectal trials provide you with a lot of ammo to answer all these questions. And in the most recent years, there have been more and more papers published on that actually the overall costs of laparoscopic colectomy are actually less than for open colectomy, even with the greater cost of the equipment and the longer OR time, because these patients, they tend to be discharged earlier. Now, this is probably the most important thing that I have found that is absolutely crucial to the, excuse me, to the success of laparoscopic colorectal surgery. You need to get the OR nurses on board with you, because if they are not happy, you are going to be miserable in the operating room. So once you have identified the nurses who are going to be on your team, get them involved, print out papers for them to read, give presentations to them about laparoscopic surgery, arrange visits to other hospitals where you are familiar and they are doing laparoscopic surgery, have them visit with the other OR nurses, go there during cases, see their setup, etc. Make sure that they get invited to big conferences like SAGES. I have arranged for the people who like Covidian and Ethicon and more producers to have a grant for 2 OR nurses every year to go to SAGES. And they're mostly going there for the for the show, for the industrial show, to look at the technologies and what's coming up. But they also go to the conferences, and they absolutely love it. And this has been essential to keep them involved and keep them abreast and knowing what is coming up. So they are always willing to discuss new equipment and new and better ways of doing things. And I think it's very important when you're starting out to have the OR nurses go by the floor a day or two after the operation and show them the patient. The patient is usually on the verge of being discharged on day 2 or 3, and they are used to big open incision, the patients being in the hospital for a long time, and to have them just come with you to the floor for a few minutes, say hi to the patient, and see them up and about, walking around, having lunch, joking, it's absolutely priceless. And if there are any skeptics on your OR team, this will usually win them over. Now, you won't do any operating unless you have patients, obviously. So it's important to get your name out there and let the people who are going to be referring to you know that you are in town, you're in business, and this is what you're going to be doing. The gastroenterologists are probably the most important people you need to convince to send patients to you, and that laparoscopic surgery is a good thing for the patients. The primary care doctors and the oncologists are important as well, but the gastroenterologists are the ones who are going to be finding the polyps, the cancers, even the diverticulitis patients. So you need to get on their good side. And a way to do that is to check out local meetings. Are there any journal clubs? Are there specific sub-meetings like an IBD group that's interested in laparoscopic surgery, or a pelvic floor group in your area? So it's important to ask around, find out where the people who are going to be your referral base are, and go to them and volunteer to give talks and participate. Because if you show interest, then they will come to you. Now, your first cases. This is very, very, very important. You need to pick them carefully. My first case, laparoscopic case, I didn't book it until 4 months into my practice. I waited. I was being very patient. But then after 4 months, my patient gave. And I felt, here I am. I'm this laparoscopic colorectal surgeon. I've been here for 4 months, and I've been doing open colectomy the entire time. So it's time. So my first case was a heavy-set woman who came into the hospital emergently with colon stricture from diverticulitis. It was probably the worst patient I could have started with. The only thing that could have been worse was if she had had a perforation and a big abscess when I got in there. So needless to say, the case was a disaster. I had to convert after about 45 minutes because there was absolutely nothing I could do because of adhesions and fibrosis. And I felt like a complete failure. I thought this was terrible. But much to my surprise, the OR team was so happy with the case because they were so excited that we were going to be doing this. And they were so excited that the setup got off okay, and that we were at least able to mobilize the splenic flexure before we had to convert. So the patient was happy too, because I had prepped her very carefully that it might not be possible to finish the case laparoscopically, and she was just happy to be able to eat. She hadn't been able to eat for a month. So as long as you keep your expectations, the patient's expectations, and your team's expectations real, it doesn't matter really if you have to convert or not. It's important to have an experienced assistant. You don't want to be doing your first cases with an intern on the camera. That's very important. And like I said, keep the expectations real. The setup is going to take a long time for the first cases. There's going to be problems. The overtime is going to be longer. So don't book a lot of other cases along with your first laparoscopic colon case to begin with. Just take your time. I think I would like to conclude with 2 points that may not have to do specifically with the title of the talk, but they are very, very applicable to starting your career as a laparoscopic surgeon. Pay attention to the pain in your joints, because laparoscopic surgery places a lot of stress, especially on your wrist and your thumb, and also your elbows and your shoulders. So if you start having tenosynovitis in your joints and aches and pain, put the ice pack on immediately, take some ibuprofen, take this seriously, because this can get pretty bad if you don't pay attention to it early on. And the second thing is that nobody is going to talk to you about how tired you're going to be your first year in practice. You're going to be looking forward to getting out of residency, getting out of fellowship. You're finally getting a decent pay for your work. You're not taking in-house call anymore, and you anticipate this to be this big freedom, finally, from all the hassle of residency and fellowship. But with the responsibility of finally being the attending, being the one who people are calling, you're not making the phone calls anymore, people are calling you, it carries a heavy burden, and it's very fatiguing to finally be on your own. Just remember that you are as alone in your practice as you choose to be. So keep an open line to your mentors. Keep in touch with people who have taught you and taught you well, and talk to them frequently. And when those first complications start to hit, talk to your colleagues about them. We all have them. It doesn't matter how good we are. It's just a matter of time before something horrible happens to you and your patients. So be prepared. Use your time well now while you're in residency to get everything lined up. Starting something new can take a long time, and you just need to be patient. You will get there. And it's very important to be prepared for failure and how you're going to deal with it. And most importantly, keep track of your results, because you are going to remember all the bad cases. You're going to be remembering every single anastomotic leak that you had. But you're going to forget all the people who went home on day 3 and came to see you at their 6-week follow-up and gave you a hug in the office. So keep track of your results to keep your expectations real. So I think that's it for my talk. John, do you want me to address that question now, or do you want to save that for the discussion later?
I think for time's sake, why don't we get that at the very end? Elsa, thank you. I think I can speak for everyone. That was really a tremendous talk, a heartfelt talk, and all of us can remember what it was to be there, and I think you've really driven it home. It's perhaps a little fresher for you than for some of us, and that really really did things justice. So actually, Elsa, why don't you answer that one question from one of the audience? How do you develop a team within the operating room when you're first getting started?
Well, at my institution, the nurses are dedicated to a different specialty. So the general surgery nurses are usually the same nurses all the time. We don't get the thoracic nurses or the urologic nurses. And the ones who are more interested in laparoscopic surgery tend to seek out those cases. So it's important to find out who is really and truly interested, and then talk to the nurse manager about building a team of laparoscopic nurses, and make sure that that team gets special training with all the equipment and the instruments and the staplers and everything that you need to troubleshoot. So it's really important to have the nurses on board and the managers of the OR nurses working with you to establish a team that's always there with you.
All right, well, thank you very much, Elsa. And if it's late and you're going to go to sleep and not last till the end, we understand, but hopefully you'll stay around.
I'll try to stay awake.
Hey, well, we're going to change the schedule a little bit for technical reasons and segue to Dan Geisler, who's now at Allegheny General Hospital in Pittsburgh. Dan is going to be speaking to us from single-port colorectal surgery, when and how to do it. He's just recently left the Cleveland Clinic and probably has the biggest experience in the world with single-port surgery. This is why you want to, now, I'm not sure Dan's web camera is working, and he told me that his mother told him he had a face for radio. So with that, I'm going to turn matters over to Dan Geisler.
Hey, thank you very much. Can you guys hear me?
Yes.
I'll take that as a yes. Great. Welcome, and I thank you guys for joining us. And let's see if I can get this to go. There we go. First, since single port is still somewhat in its infancy, I'd like to echo something that one of my mentors taught me, which is to try keeping things as simple as possible. Try not reinventing the wheel, but try making the operation very straightforward and do the same operation that we've been doing for years. I'd also like to echo something Dr. Randy Bailey said in his presidential address to the American Society of Colorectal Surgeons, which was entitled A Lifetime of Learning. I always feel obligated in a way to say that when we're talking to a bigger group of residents. You're going in the best profession. It's a very noble profession. You're learning a lot now, but you're going to learn a lot more, or at least have the opportunity to learn a lot more when you get out. I spent extra time in training, and after I trained some more. Some might say that I just needed some more seasoning, but really here in 10 years in practice, I feel like I'm still learning new things and hopefully going to be able to take surgery to the next level and then progress beyond that. My roots really date back to time in Philadelphia. Dr. John Marks always says that he's contractually obligated to show this watercolor by his dad. This was by far the best year of my training, spending an extra year with Dr. John and Gerald Marks, doing minimally invasive surgery, learning a novel way to do an operation. Dr. John Marks had brought a pretty unique technique back from Europe. That had been started by the likes of Dr. Joël Leroy and Christiana Hoosier, and spent a year really keying in how to do a advanced operation, but in a simplified fashion. Shown here is a little diagram on how we would attack left colectomies through a 3 trocar technique. And if you think about it, a camera and then the surgeon's working through the other ports. If you can do it, it's going to really simplify the operation. For right colectomy, the same type of thing. Of note here, though, when we start talking about single ports, one of the questions is going to be, what all are we going to gain by it? When we have this number 1 incision and we're getting rid of possibly 2 5 or 10 millimeter ports, does it make that much of a difference? We'll try to answer some of that today. I took my show on the road, spent some time at the Cleveland Clinic under the guidance of Dr. Vic Fazio, who will always remain in my heart as a pioneer in the field and as a true innovator and someone who really takes a thrill out of taking surgery to the next level. Someone who the leadership has led the department there to wonderful heights that hopefully can be sustained with time. So single port laparoscopy, we all know that natural orifice surgery is evolving in that we can use a natural body orifice or an embryologic natural orifice such as the umbilicus. However, this still remains experimental, and single port laparoscopy does seem to be a practical next option. I had to throw this in. This was one of my first patients as I've just relocated to Pittsburgh Allegheny General Hospital. This is a 13-year-old kid with familial polyposis. When he came in for his follow-up, his dad, we didn't have a ruler, so his dad said, why don't you just put a quarter next to it because that's about the size of the incision, and that's the only incision. At 4 weeks out, this is pretty much what's left, so cosmetically, obviously, a wonderful new way to do things in a very minimally invasive fashion. This really started back in 2008. On the left of your screen is Dr. Jiad Kayuk, who is one of the star urologists at the clinic. He introduced us to, clinically, to single port surgery, something I had been working on in the lab, doing human cadaveric and live pig models, but bringing this to light. And this led to the first case report of a single port hemicolectomy, which was again reported back in 2008. As you can see, again, pretty minimally invasive incision on a patient who's a little on the fluffy side, and this was for a right colectomy. At that time, we were using very primitive ports. This is the R port. We've used the P naval. We then graduated on to these ports, and I think I've used pretty much every port out there, and have thought these two are the most noble of the ports, but have really graduated to using just the SILS port, just because I think, going back to my first slide, keeping things simple. I think if you played with this or even looked at it at a meeting, you'll agree that it's overly simple. It seems too simple, but I think that does set up for a very nice operation. And as this slide shows, this is typically what we do, go through the umbilicus. Unless we're doing a temporary stoma, you can use a stoma site, so pretty much have an incisionless surgery afterwards where they just have a stoma. This slide just depicts the instruments, and I think this is one of the benefits of doing single port over pure laparoscopic surgery, is that we talk about triangulating, and unfortunately sometimes you work against yourself. With single port, you're usually working directly at the pathology, and if you can keep one of those trocars out of the way with use of an articulating camera, you can really make for a nice operation to where you're working directly at the pathology at all times. When I do a right colectomy, this is what I like to see, a nice high ligation of the ileocolic vessels, the terminal ileum, cecum, ascending colon, hepatic flexure to the mid-transverse colon. If you can mobilize all of this, you can usually get it up to a very small incision, shown here measuring less than 4 centimeters in size. The industry has been very quick, unlike in the 1990s when lap colectomy was just being devised. The industry has come up with a lot of interesting instruments. However, I've abandoned most of these for the time being until we take the next step, which I think is going to be transvaginal and possibly transanal work, because I haven't found the need of using articulating instruments. Again, trying to keep things as simple as possible. So therefore, what I typically use in a case, 5 millimeter Olympus endo-eye camera, keep that camera out of the way, and then use the instruments you're used to using in regular laparoscopic cases. For me, that's a straight laparoscopic grasper in the Ligasure 5. I think, it keeps things incredibly simple. I'm working directly at the pathology and expediting the case. My early experience, my first 106 cases before I left Cleveland, primarily right colectomies at first, and then I really jumped into doing restorative proctocolectomies, which can be a tremendously enjoyable operation when you're doing single incision. The disease process is shown here. There was one mortality, and that was someone going into cardiopulmonary collapse post-op day 1, a very elderly, infirm female with ruptured diverticulitis. So SILS, I think, good starts. Right colectomy, I think, is something obviously that we've preached years ago when you're learning regular laparoscopy. Right colectomy is a more straightforward operation. However, in my patient population, I think the ones we see the biggest benefit as far as recovery, going home sooner, and less pain are the sigmoid colectomy, left colectomies, and total colectomies. When you're working through a small umbilical incision, not having any other incisions, those patients seem to benefit the most from not having a muscle-splitting extraction site. So the current use is expanded. Restorative proctocolectomy, probably the biggest operation we do as colorectal surgeons, and let's see if I can get this to play. I'm not sure if Steve is on there, and let's go to the next slide. I think we've got the same thing on here. Here we go. So basically, typically 1, 2, 3, 4 incisions for a restorative proctocolectomy, with that suprapubic incision enlarged to 3.5, 4 centimeters to remove the specimen, using the SILS port just through the pre-marked stoma site. We can usually do this entire operation just through the stoma site itself. Again, very easy application of the ports. And what you'll see here, I think, in any operation you're doing, you need to explore the abdomen. You don't want to be a surgeon that does a major abdominal operation and then misses some pathology inside the abdomen. Shown here and on the left of the screen will be Dr. Kelly Garrett, who's joined Jeff Milsom up in New York. She's, in my mind, a star at minimally invasive surgery. A true pleasure to work with. But as you can see, keeping that camera out of the way, we are working out of a right lower quadrant incision site, which will typically be a little goofy at first because you're right on top of the ileocolic vessels. As you progress the operation and go through the middle colics, and especially working on the left side, you have much more room to work, and you're able to work a little more directly and not up and down. This part of the operation might look a little more boring to you. It's typically just like a regular laparoscopic case. Same principles that we use. I just taken the ileocolic. Each part of the operation, I tried preaching to the residents what could go wrong here. Obviously, working medial, you have to be aware of the duodenum. As you're working lateral, again, at some point you're going to encompass the duodenum as well as the gallbladder up top. And I think those are cardinal sins, that if you have some extraneous damage, especially if it wasn't identified at the time of surgery, those are the things that you really, whether it's single port, regular laparoscopy, you must be able to avoid. This is a key part of the operation where you're starting to take the right branch and the left branch of the middle colics in sequential fashion. If they're thin patients such as this patient, we're frequently able to take both the greater omentum as well as transverse mesentery together with the ligature. And that's one of the many reasons I sing the praises of industry is not having to ligate vessels, not having to put in ties, really expedites the operation to allow you to perform it very quickly. We just had identified the ureter and then took the inferior mesenteric artery. In the last probably 500 or 600 conventional laparoscopic cases, I probably used 2 vascular staplers during that time because the heat sources do work. There are other ones out there. I typically use this one just because I found that it's tremendously safe and lets me sleep best at night. Deep pelvic dissection, working straight in the pelvis. I think one key you notice in this video, but pretty much any of my laparoscopic videos, I try not grabbing a lot, and I try grasping once and utilizing it for everything I can, working down in the pelvis. And I love videos where you actually don't even see the grasper. You have good tension, the grasper's out of the way, and here we are just going across the interior reflection as we work our way into the pelvis. So some other things, I told you that part was boring. This is really the meat of the operation. You see the camera nice and out of the way, and then the surgeon working very naturally, directly at the pathology, not working against himself or herself, and making a really straightforward operation. As you progress the operation around the middle colics, you're not working as much above the abdomen as in that picture, and it keeps things nice and simple. The ports do allow you to put a stapler down, and you can see the anterior reflection. Same thing, personally, I mean, if a J-pouch patient develops a pouch vaginal fistula, no matter how it's done, it's a devastating consequence. I think with laparoscopy, you can visualize things much, much better and hopefully avoid some of these awful complications all the better. And then the specimen, almost like a bad late-night TV show where you have a little 2-centimeter incision and you bring out 5-6 feet of colon. And I would take this opportunity to say, and I've done this on morbidly obese patients, there's no way I'm going to take a specimen that measures 6, 7, 8 centimeters out to a stoma site. So in those patients, I'd be very quick to make a counter incision somewhere else, remove the specimen that way, to better help avoid getting a peristomal hernia. As you can see, about an 18-centimeter J-pouch configured. That tucks back in. In a thin patient like this, occasionally it's a little tough getting even a 28 or 31 anvil back in through that small incision. So I typically don't enlarge that incision because I don't want to lead to a peristomal hernia. On a nice thin patient, it makes for a very nice and cosmetically pleasant view here. I think Dr. Young-Fadok's on. I think she has one up to me on this during these without drains. I think I don't see any problem with that because, again, most of us who do these keep a very bloodless field, so really there's not much in the way of drainage afterwards anyway. How is the learning curve? I've heard over the years, and I was just sharing with John Marks at Phil Schauer's MIST meeting last month, that remembering him getting attacked, you can't preach that you can do it through 3 trocars. You might, but others can't. And then I quickly picked up on it. Elsa is a star, not just in the OR, apparently, by the talk she just gave, but with some of the logistics of practice. But it is feasible, and it is not only one person or 5 people or a handful can do it. We've had over 100 surgeons come in to learn this. All did have a good laparoscopic experience, and they all went out and quickly performed SILS cases. I don't think that means you should do a one-day course and go out and do a SILS lower anterior resection for any radiated rectal cancer as your first case. But I think if you have the background with minimally invasive surgery and you're humble enough to take things in the right direction, then SILS is a very, very doable operation. The surgeons we've had have been put out some wonderful information and comments. Harry Papaconstantino, who's at the Scott and White Clinic, I think has been progressing SILS at an incredibly quick pace. He does have a manuscript pending looking at right colectomies, single incision versus laparoscopic versus hand assist, and is actually seeing significantly better recovery. And length of stay is shorter in the SILS versus hand assist and regular laparoscopic. And so I think we're going to start, as we grow, see much more intriguing information as things go on. So what are the real advantages? Well, marketing. When I was in Cleveland, I think with a lot of things, they do a lot of marketing. It really was 6, 7 years in practice before I had patients really coming in looking for laparoscopy. It was really within 12 or 14 months since we did our first SILS case that I had patients knowing about single incision and wanting single incision and wanting the least invasive surgery. Cosmetically, I think at least somewhat improved, whether you're skipping a couple of 5s or 10 millimeter incisions, it is somewhat improved. But the thing that really got me sold on this is looking at my OR time. And I'm a simple guy, so I wanted to look at our biggest operation, which is a restorative proctocolectomy. In our first 13, and I showed the numbers before, we've doubled this number. Our first 13 we compared during the same time frame to the open surgeons, and these were some of the, again, the pioneers in colorectal surgery during open surgery. Typical J-pouch time was 196 minutes during that time frame for laparoscopy. Not bad, 211 minutes. For SILS, though, 167.8. So a bit less. I've been asked, well, is that because I'm doing the case? I would hope if you talk with any of the residents or fellows I've trained, they'll tell you that they get very involved in the case. And I think there's nothing that I take much more pride in than having a resident and get them through a case like that and then seeing the patients do tremendously well afterwards. So thinking that, hey, it's possibly a better OR time, and this has been echoed by some others as well, is a very intriguing concept. Can we simplify things even more? So in closing, some suggestions as far as single port colorectal surgery: be modest. When I did my first, I went from doing rights to doing J pouches. That doesn't make a lot of sense to most, but it was with a very modest calling, thinking, you know, I need that stoma site anyway. Putting a SILS port's not going to hurt that stoma site. Let's see what we can do. If I needed to put a 5 millimeter port or 12 millimeter port or 3 of them in, so be it. But let's see how much we can do that way. And lo and behold, we were able to do a majority of the J pouches just through the stoma site itself. Rights are a great way to start, but lefts are really the patients that I'm seeing the biggest improvement in recovery on. If you need an extra port, put in an extra port. I always counsel my patients, hey, we're going to do things in the least invasive fashion for you. If we can't do the same operation that the pioneers have been doing in wonderful fashion for years, we're going to modify things, and if we need to make a big incision, that's what we do. Other suggestions: articulating camera is wonderful. It really keeps one of the 3 ports out of the way. Articulating instruments, I I used those in my first case and really haven't used them since. Part of me does kick myself now as we're trying to make the jump into doing transvaginal work, which I don't think is that far off. But articulating instruments are not an absolute for doing Phil's cases. Another thing I learned along the line, having people like Carrie Papaconstantinou out there, obesity instruments. If you don't have a articulating camera and you have the camera person's hands next to your hands, if you can use an obesity instrument, that at least keeps one hand a little further away. So it does help to keep the hands apart, which helps in facilitating performing the operation. So what are the proven benefits? Well, I mentioned some, which is pending, and Harry's work will show that, I believe, in American Journal of Surgeons here soon. At first, though, we didn't see any real benefit. What is the difference between getting rid of 2 or 3 5 or 12 millimeter ports to saying, hey, 5s are free? To some degree, I would agree. To other degree, I say, well, obviously that's not completely the case. Potential associated morbidity can be less because we're not putting a hole in some organ that's not involved. Practicality and feasibility, definite. That SILS is definitely practical. It's definitely feasible. I think someone who is comfortable doing regular laparoscopic surgery can make the transition very quickly. So where are we going with this? Boy, we've taken this one little incision and put it through a 2-centimeter incision, either through the umbilicus or through a stoma site. Why can't we put that transvaginally, at least in half of the population out there, or why can't we put it transanally? I think it's very intriguing. I think we'll probably need to incorporate articulating instruments as well, but I think it's going to be doable. It's just how do we get there, and fortunately I don't think we're that far off. So finally, single port laparoscopy does minimize abdominal trauma at least somewhat. There is potential decrease in morbidity, certainly somewhat superior cosmesis. While NOTES is experimental, single port laparoscopy does seem to be the practical clinical step towards NOTES, and finish by saying it's definitely a bridge to the future. So I thank you very much for your time. I always like leaving this quote by Dennis Parsons Burkitt, who was best known for Burkitt's lymphoma, but was really a colorectal surgeon at heart. I commend you guys, the residents out there. Learn everything you can during training, and then when you get your feet on the ground and practice, keep your eyes open and keep learning and take whatever avenues you need. So I thank you very much.
Thank you, Dan, for a great presentation on what's out there and where you've taken things, and many others have taken things for single port surgery. I think what we're going to do now is just jump into Tony Senagore's talk, and then we can handle questions afterwards. We're happy to have Tony on board talking about.
Thank you, John. Let's see, I think I can control my slides. I think I've enjoyed the talk so far, and Elsa's was actually a very good lead-in to mine. Unfortunately, I think the title that there's tricks really belies reality, and it's really not tricks. It is just hard work. And so what I really want to focus on today is a construct of what is required for training, the impact of focus training, and then come back to a strategy for a straightforward approach to an operation. So I'm not sure I can figure out where the next slide is here. I got pointer. There we go. So this is the battle plan that was presented to Petraeus when he took over the war in Afghanistan. This was given by a captain at a briefing. And basically it gave the overall plan on how to win in Afghanistan. At the end of the presentation, General Petraeus said there will be no more PowerPoint presentations at any future briefings. So it is a fairly complex approach. But what I really want to say is laparoscopy really does not need to be this complex. We really need to break down the procedures, much like Elsa said, much like actually Dan Geisler said, come up with a set of steps that seem to work for you, that make sense in your operating room and with your team. Despite all the very advanced speakers here, this is about the most recent data looking at adoption of lap colectomy, and we woefully lag our colleagues in other surgical fields in terms of the adoption of MIS. And really optimistically, I would say it's probably under 30% still today in terms of overall colectomy performance. And that's why, even though folks suggest that things like SILS may be easy to learn for those that do laparoscopy, I think going from open to SILS without a lot of support is probably a major leap. So you really need to have a structure of how you want to bring laparoscopy into your practice. So when you look at the learning curve, I think you have to set your own goals. Now, I think a lot of the audience is in training, so you're going to get a lot of this exposure during the training program itself, and you should have graded experience as well as graded support to get through the procedures. But if you're on your own, these are still things that you'll have to remember, because when you go out on your own, depending on how much support you have from your partners, you will have to have some structure about successfully completing an operation. And these are really, I think, all the things you have to consider. Speed, I think, is probably the last thing, because even in the olden days with open surgery, you got more proficient as you got more experience, because speed to a large degree comes with confidence. But, you know, setting milestones for successful completion of steps, ultimately in culminating completing the entire operation, certainly complications and costs matter, because that's going to impact your reputation, as Elsa said. So it's better to have a safe operation rather than trying to press ahead in the face of adversity. Clearly, there's a whole variety of data showing the impact of volume, and you can see that both surgeon volume and institution volume play a role in successfully completing laparoscopic colorectal surgery. It seems intuitive about the surgeon that the more you do, the better you will be, but you can't underestimate the impact of your overall team. You still are highly dependent on the circle nurse for instrumentation, someone to make sure that the instrumentation is working for you, particularly the insufflator, cameras, etc. So you really have a team that needs to know your steps in the procedure, knows how the instrumentation works, can troubleshoot the instrumentation for you to have a successful outcome in laparoscopic surgery. What about does volume lead to better surgery? Here it gets a little bit more difficult to understand. This was an article by Bill Moria looking at oncologic outcome, and they basically used lymph node retrieval as a surrogate. Again, I think that's problematic in terms of is lymph node retrieval a be-all and end-all for cancer surgery? But they did find a difference, indicating at least that maybe there's a comfort level with a bit wider resection in the highest volume of experience. Interestingly, really nothing else changed that matters, and particularly survival would be the most important benchmark. So you have to take this study with a grain of salt. But interesting in that article, when they looked here at overall cancer survival, and interesting to see in the right upper quadrant, high volume was only 9 cases per year, which would seem fairly modest for a laparoscopic colectomy. But there was a little bit worse survival overall when they looked at data out 60 months with open versus laparoscopic colectomy. And this margin actually parallels the multi-center or the single-center prospective randomized trial from Spain a couple of years ago by Antonio Lacey. Looking again, another article looking at surgeon volume and institutional volume, and you can see that once again, performance has improved overall in terms of overall outcome in the highest deciles, with mortality being the surgical volume as an outcome. There's a little bit different outcome in terms of mortality by institution, but you could see that there was probably some staging effect for risk adjustment, which was not controlled in this article. So when we look at volumes again for credentialing, because this is the other issue for the trainees that are just getting ready to finish, you'll meet this new word when you go to your new institution, and that'll be your approval to do operations. You can lay claim to the cases that you have performed in residency, but they will need to look at something for volume. And this is going to be an issue I think, going forward for recredentialing, because this has now become at least a biennial event at most institutions. And as you fail to do certain procedures, for example, I haven't done a thyroidectomy in a long time, it's very hard to argue that you should maintain credentialing in an operation that you don't perform any longer. So we don't really know the numbers that are needed for credentialing. We can talk about learning curve, and we'll see numbers in a little bit, but the learning curve initially for colectomy is probably, for laparoscopic colectomy, is probably somewhere between 40 and 60 cases, depending on the training facility and how much access you have to a mentor while you're learning. But once you master it, what is the volume to maintain it? That slide I showed just a bit earlier said that outcomes were pretty good at 9 cases a year. So we really have to struggle with what is the difference between initial training, initial credentialing, and maintenance of credentialing going forward. And the quality metrics I would submit are pretty elusive right now. But when you look at learning curve volumes, you sort of see these typical curves for double peaks, where in an initial approach, there we go. So initially you get pretty good at the straightforward cases, and then you take on a bit more complex cases, and then you get better again, and then you kind of level off. And so, the number ranges between 50 and 60, I think, for that break point in most people's experiences. This is some work we did back when I was in Cleveland looking at volumes, and you can see that, the bulk of the learning is really in the first 60 or 70 cases, although there is some slow, steady improvement over time, like anything in life. But the marginal difference in terms of quality is probably pretty minimal after about the first 60 or 80 cases. Looking at risk of conversion, again, you have to take a little bit of this with a grain of salt, because early on in our experience, there weren't instruments that were as flexible, particularly the energy devices that we now have access to. But still, it can show that a general trend over time is that conversion will be less frequent as you go forward, and completion of cases will become more frequent because you're more confident in dealing with complex scenarios. This was an interesting look, though, from Brad. I think, unfortunately, this argument has moved on from, in this case, straight laparoscopic and hand assist, because now we have cells. And I guess one could argue that hand assist really has been relegated to a distant third place, maybe just ahead of open surgery in terms of overall outcome. But this was an interesting look at one resident working with 2 different teams within a training program, and what was the percentage of cases completed. And actually, it was almost significant that the straight laps got completed more frequently. Clearly, there's a smaller incision, but there was really no other difference between the two with training. But it was interesting in this article in terms of when conversions occurred, there were actually more conversions in the hand assist than there were in the straight lap. And a lot of the things that have been propagated related to hand assist actually seemed a bit more difficult compared to the straight lap. One could argue there was maybe some selection bias in the cases, but I think in that faculty group there were sort of 2 camps in terms of how procedures were performed. It's unlikely there was a big variability in the indications for surgery. So again, sometimes urban legend can be a little bit fleeting when faced with reality. This was an interesting paper actually from China, and the benchmark here was the percentage of cases in the operative time where the trainee could complete the case with less than 50% in intraoperative supervision by the trainer. And so again, you can see that same break point of about 40 to 50 cases. Times came down, a bit more complex surgery, still completing cases by themselves at that break point of less than 50%, and then another drop in the curve over time as they were able to master the more complex cases. So now you're trained, now what happens? What about experience over time? So this is data from the cost trial. Now, I guess retrospectively, since I was on the trial, I would say we were probably optimistic about how well trained we were going into the study. The benchmark was 20 cases to be able to enter as an investigator. I think we all know a bit more is probably realistic. But what happened to the postoperative outcomes in people that did low, medium, and high volume within the study, but had a similar benchmark at the start? And really what you can see is that the length of surgery in the higher experience was better in terms of shorter, I guess. And as you look at that would make sense that these people actually went on and completed a more aggressive learning curve during the course of the cost trial, actually, compared to those that accumulated less volume during the study. Experience in survival, though, again, the oncologic differences weren't significant. And I think this is important, that if you have a construct on how to do the operation, speed by itself is not the most important issue. Clearly getting it done sooner than a calendar day would be helpful. But the difference an hour or so for the operation is not clinically relevant. And again, if you focus on the most important outcomes, which in this case would be cancer resections, the oncologic outcome should be equivalent. Looking at overall survival, again, this shows, again, the oncologic outcomes were not different between the three groups of surgeons within the cost trial. So when I was at Cleveland, we built this model. It doesn't work for every site because it was a bit unique for ours, but it kind of gives a frame of reference of complexity. And I think to build on Ilsa's talk, something to at least put in the back of your mind when you're selecting cases as you start out. Clearly, to start out with a BMI of 40, an ASA of 4, and a complex pelvic abscess with colovesical fistula might not be the ideal case for your first one in practice. So you want to be able to build a program where you can slowly move on and get those things sorted out over time with simple cases, because you have to, again, train your team. So you have to keep that in mind. So I'm going to kind of segue here into what I think is a standardized approach. It's one that I use and teach. With all full disclosure, I am not sure I've embraced single port yet. I still am a little bit suspicious about the overall clinical benefit. So I still do old-fashioned straight lap. But this is my construct for a sigmoid colectomy. I think it allows specific steps to be performed and mastered, and I can hand off a case with early trainees and let them progress through the steps, and when they can't progress, they understand what the next step is and maybe how to get out of trouble where they've reached a stopping point. So this just shows the IMA being elevated here, and then we'll enter to the right of the mesenteric base and open up the plane to identify the ureter. The beauty of the medial to lateral approach, this just shows the pedicle being elevated, is that when you elevate the mesentery, even in complex scenarios, the ureter is the first structure that you find. I really would counsel you to try to master this medial to lateral approach. When you go lateral to medial, unfortunately, everything begins to look like the ureter, particularly in diverticular resections where there's inflammation. You can be confused by the psoas tendon, by the gonadals, and actually even by the ureter. So I really do like the medial to lateral approach. I think it's safer. If you can't find the ureter here, it's going to be a very difficult case, and that's, for me, is still a red flag that I'll be converting. You can divide the vessel by any technique. This really shows an old-fashioned way of clipping it, but there are a variety of other strategies for that. This shows the completed dissection from a medial to lateral perspective. I think it's important to understand that what you want is to keep this translucent layer over the ureter, this Tolt's fascia, which is the fascial layer that covers the retroperitoneum. It's the embryonic parietal peritoneum when the colon eviscerates itself and then returns back to the abdominal cavity embryologically. This is actually the fusion plane between this native serosal surface and the serosal surface on the colon and its mesentery. And so if you stay in this plane, the ureter should be well protected because it's actually beneath this layer. Then you divide the bowel, and once this is divided, from this point, the case should go very, very well. So if you look at this strategy over time, we actually looked at our conversions. I still run about a 10% conversion rate, being fairly aggressive on who I do laparoscopic bowel resection on. But importantly, what this slide shows is that 50% of the time, conversion happened in that first step or two, where I couldn't mobilize the vessel off the ureter. I couldn't find the ureter clearly. I couldn't identify that safe plane and decided to convert at that time because the planes were too obscure to proceed laparoscopically. Only rarely with this stair-step approach do I get caught late in the case and have to convert prior to completion. So it just shows this is 1,000 consecutive cases that I performed at Cleveland, and it shows the broad mix of cases that we do, a reasonable mix of BMI for these patients, and a reasonable OR time with a structured approach and a conversion rate that's around 10%. And I think that laparoscopy has consistently demonstrated, in conjunction with an enhanced recovery program, that the length of stay is routinely less than other techniques for colectomy. So if we use the aviation metaphor, which I think may be overused in medicine, but clearly some stair-step approach to mastering basic laparoscopic skills. These are things that are easily being mastered now by either box trainers or some new virtual trainers at the earlier resident levels. Residents now are obviously doing far more laparoscopic cases, so now they're coming to colectomy, learning to do colectomy, not having to learn how to do laparoscopy. So I think building on Elsa's talk, and I think the fine talks of the other speakers, unfortunately it is practice, 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 but most importantly it's structured practice. You need to have a game plan to do this. There are unfortunately very few real tricks. There's just an understanding of the anatomical planes and a way to master each step to completion, because I think the easiest way to get confused in laparoscopy is not to complete an individual step. It's very hard to go back to a site and reacquire that facility. So, learn the skills you have in residency, understand the operation, and understand how you and your team interact, and it should be successful for you. And once again, it's great to participate in the talk tonight. Thank you.
Tony, thank you very much for a tremendous talk there, as always. And I think what we'll do is ask everyone into the chat area. And what I'm going to do is we've had some great questions come in, and maybe what we'll do is start off by putting out to the group, and Tony, if you're still there, perhaps you can answer, as to how you suggest assembling a team and maybe some tricks you've used to get some buy-in, because all of us recognize that that's an incredibly important thing to having a successful program.
Yeah, I think Elsa brought that up nicely. I think you really have to have a team that understands the instruments in terms of your scrub tech and your circle nurse. And I find that with residents, it's very important to do a verbalization of the steps of the procedure before we start. This way it's clear we both understand what we're going to look for and in what sequence. And then a lot of times as they get more mature, all I really have to do is kind of reboot them at a stage where they think they're stuck. And they're able to rethink their way through that one step and then successfully proceed from there. So I think to be able to articulate a step, and I think Eric Darcy had a very nice article recently about that, about mentally rehearsing the procedure before you start is a great way to do this.
Anyone else have any comments you want to add to that? While we are looking at that, perhaps we can touch some of the other questions. Dan, someone asked, is it possible to do a no-touch technique in sills, and is that a problem? And ergonomically, what do you have to say about doing sills colon surgery?
Well, I would say that I think you can do as much of a no-touch operation as possible. I greatly enjoyed Tony's talk. I always looked up to him as